So welcome. I will call this meeting of the Board of Health to order. It is now 6:34 p.m. and we'll start with the roll call. So if you could answer here when I call your name, that would be great. Dr. Tyra Bryant-Stevens.
Here, sorry, what's on mute?
Sorry. Dr. Ana Diaz-Rue.
Here.
Dr. Marla Gold.
She said something.
Oh dear, there's something dreadfully wrong with your sound.
She's here.
We recognize you as here. Oh dear, I hope that's fixable. Sorry, and Dr. Jen Ibrahim.
Here.
Dr. Hamid Ismail.
Here.
Dr. Scott McNeil.
Here.
And Dr. Ayla Stanford. And I believe she is absent. Okay. So I'm now going to turn to Ben for an explanation of the public comment process. Ben?
Thank you, Dr. Bedegal. Good evening, everyone. My name is Ben Hartung, and I'm the Public Policy Advisor for the Division of Chronic Disease and Injury Prevention at the Health Department. And I'll be facilitating the public comment process tonight. The way that will work is that there is a question function in the GoToWebinar that you should have access to submit questions. There is also a chat feature if that's not working for you, where you could submit questions. And the third option is to send me an email directly. My email is benjamin.hartung@phila.gov. That's benjamin.hartung@phila.gov. And I will note, board members, that we have received a couple emails that I've sent to you to review already this evening, and I expect, because we do have members of the public present right now, that we'll be receiving other questions. And members of the public, I'll just note that at this meeting, the board members are required to review your questions and consider them before voting on any of the agenda items that will be heard today before the board, but they do not have to respond directly to your questions at this meeting. I will make sure that the board, any questions that are put in the chat or in the questions box or emailed to me are displayed to the board members before any vote. So thank you very much.
Can I ask if sound is better, please?
Yes, much better.
That high-pitched Mickey Mouse is gone? Okay.
Yes, we miss it, but great. So I'll just note that this public meeting is being recorded and will be posted online per city ordinance. Your participation in this meeting constitutes consent thereto. So next, we'll review the agenda for tonight, which is firstly to vote to adopt the meeting minutes from January 4th, 2022. Then a presentation on regulation regarding blood lead level testing in children with Dr. Stacy Callum. Then a regulation regarding blood lead level testing in children. Then rescission of the regulation relating to the sale of flavored tobacco products. Then an amendment concerning the effectiveness of the emergency regulation governing the control and prevention of COVID-19, mandating vaccines for individuals working and dining at indoor dining locations, as amended January 4th, 2022. And then the third consolidated and restated supplemental emergency regulation governing the control and prevention of COVID-19, consolidated safety measures for full reopening and delegation of authority. So we have a very full agenda. So I'll ask next if the board has reviewed the meeting minutes and if there are any questions. Is there a motion to approve the minutes?
So moved.
And second? All in favor?
Aye.
Aye.
Any opposed? Great, thank you. So we'll then move to the first of the regulations, and I think Joe will review, actually, I'm sorry, we're going to move to Stacy's presentation, Dr. Callum's presentation on the regulation on blood level testing. Dr. Callum, I think you have slides.
Yes, thank you, Dr. Bedigal. Ben, are you able to put my slides up?
I'm going to allow you to share your screen if that's okay, Stacy.
Sure.
And I'm changing you to the presenter now.
Okay, let me just. Sorry, let me just get rid of. Sorry, I'm not used to GoToWebinar. Just bear with me for a moment. Can you all see it like this?
Yes.
All right, so I'm going to be giving some context about blood level testing in children, which is the medical background for the regulation that we'll be talking about in just a moment. So first, just a little bit background on lead exposure in children's health. Importantly, there is no safe blood level of lead in children, and even really small amounts of lead exposure can have adverse health outcomes. So for example, lead exposure can slow down growth and development, cause problems with hearing and speech, behavioral problems, attention issues. And really the risks for lead exposure are most prominent if the exposure is if the child is less than 6, which makes sense because when you're a young child, you're more likely to explore the world with your hands, you put things in your mouth, and then that's how you get lead into your body. In Philadelphia, the most common causes of lead exposure are from lead paint and then lead dust. So lead dust is from sort of places of friction where there's lead paint. So for example, like doorways or windowsills can cause lead dust, which can then be ingested. And as I said before, there's no safe level of lead. There's no cure for lead poisoning. There's ways of mitigating the effects, but no actual cures, which really highlights the importance of, one, preventing lead exposure, but for the purpose of this talk, really identifying lead exposure early before it gets to higher levels. So based on that, there's recommendations for blood testing of lead. And then these are the national recommendations. So the Centers for Medicaid recommends that all children enrolled in Medicaid are actually required to be tested for lead at ages 1 and 2. And if they haven't been tested at those ages, then any time between 2 and 6 once they've been seen by a healthcare provider. For kids who aren't enrolled in Medicaid, what the CDC recommends is that you do targeted screening efforts, really focusing on either high-risk neighborhoods or children based on the type of housing stock, where older houses are more likely to have lead paint, and also sociodemographic risk factors. So here in Philly, where we have an older housing stock, really universal testing is what's recommended. I just wanted to point out that there were some recent changes from CDC as to what's considered an elevated lead level. So CDC uses what's called a reference value, knowing that no level of lead is acceptable, but they set a level which is at the 97.5th percentile of blood lead levels of all children in the US. And that was recently changed from 5 micrograms per deciliter to 3.5 micrograms per deciliter. So what's happening here in Philadelphia? This is the most recent data we have from our lead testing. So to start off is the good news. So in Philly, when we last were able to look at this data, more than 90% of kids had at least one lead screening test before they turned 6 years old. We've also seen a lot of improvement over time in the past decade when it comes to lead testing, where for kids who were born in 2016, nearly 3/4 of them received at least one test before they turned 2. That's compared to 58% of kids who were born back in 2005. But the next point is what I really want to highlight is that the recommendations are 2 tests at age 1 and at age 2. But in our most recent data, less than 30% of kids actually got those 2 tests. So that's really an area for a lot of improvement for us in Philly. Which leads us to our regulation, the goals of which, first and foremost, are to increase the percentage of Philadelphia children who are screened twice for blood lead levels by the time they turn 2. So we really want to move that metric of that 29% much higher. Also, the regulation will establish a specific elevated blood lead level standard in Philadelphia that matches that updated CDC guidance that I mentioned. And last, we want to make sure that primary care providers and pediatricians are following up with children who have an elevated blood lead level per CDC guidance. And that is all I had prepared. So thank you.
Great, thank you very much. I think Joe will then read the text of the proposed regulation to you all, and then we should open the floor for questions and comments. Joe, are you there?
Dr.
I am.
Bedell,
Actually,
Oh, sorry.
Ben is going to read through this.
Oh, I'm sorry. Ben.
thanks, Dr. Bedegal and Joe. Allow me to just show my screen, board members. Are you able to see the regulation? Okay, great. So this regulation is being promulgated pursuant to the Pennsylvania Disease Control and Prevention Act, which allows Philadelphia to establish lists of reportable diseases and conditions, as you're aware. And Philadelphia has made lead poisoning and increased lead absorption reportable conditions. Most recently, City Council in 2019 passed a bill that updated the Philadelphia Code and that required treating children for lead between the ages of 9 months and 21 months, and then again between 21 months and 72 months. The purpose of this regulation is, as Stacy described, really to implement the CDC recommendations that were most recently updated. So setting the elevated blood level at 3.5 micrograms per deciliter. And if you allow me to scroll down, I can get into the text of the bill here. You'll see that we've defined elevated lead level as the new CDC standard. And we are incorporating the CDC's guidance, which is also currently the Public Health Department's recommendations, that blood lead levels be tested at or near 12 months of age and at or near 24 months of age. So just making it explicit that within the ranges that City Council has established, that these are the preferred testing times. And then in terms of the types of testing that we would want providers to do, we would prefer a venous blood test for confirmation of that blood lead level. That is the standard for establishing elevated blood lead levels. And so the third section of this regulation is telling providers that if they have a patient with an elevated blood lead level, that they should follow CDC guidance for the follow-up testing that needs to happen when a patient has blood lead levels above 3.5 micrograms per deciliter. And as you see, we've provided a link for providers that goes into greater detail what the current CDC recommendations are. For instance, if a child is between 3.5 and I believe 9 deciliters right now, there's supposed to be a follow-up confirmatory test within 3 months. So much sooner than the 1 year gap between the 12 months and 24 months, for example. So it's a succinct bill, but we believe it will, achieve the goals that Stacy laid out.
Thank you, Ben. So any questions or comments from the board?
This is Tyra. I 100% agree with this in terms of testing, but I just want to note that this is an environmental disease that we're testing children for rather than environment. And as Stacy mentioned, we cannot do anything to cure lead levels. Once they're high, we have to watch them slowly go down, and we can definitely treat at certain levels. We can chelate them, but I really would love to see a program where we're thinking about this more as primary prevention in terms of housing, in terms of testing environment for lead, and lead exposure before it gets into the children's blood.
So I couldn't agree more. I realized that probably contextualizing this with what else we're doing on lead would be useful. So we do have the new lead certification law that requires landlords who rent in the city to get their property certified as lead safe or lead free. So there's a 2-year cycle for that to get through all the rental licenses. And so we're about a year in and we have half of them certified. So that is actually moving forward. And I think that's going to be a big way we actually move the needle here. I've also been talking with Paula Korval-Nelson, who directs environmental health, about expanding our home remediation education program so that we really are getting to the homes of all the kids who have any elevation in their lead level, doing home lead dust wipes and education with parents, because if they can have a level of 4, then the next time they're tested, they could have a level of 15 or 20, or they could have a younger sibling with lead. And then she's also working on some initiatives with daycares in the city. So yeah, I completely agree with you.
Thanks.
Just thank you. I also had a question that mostly got answered, which is we've been saying for decades about 75% or so of housing stock being old and being really the source of this. And we keep saying it. So, it's great that we're a little bit downstream, but not all the way downstream with this. I support this as well. Just a small tweak, which is I noticed in the sort of whereas preamble that healthcare providers are purely referred to as physicians. It probably was carried over for years. And then is that a reporting feature? Because later you say primary care provider. And I think there are so many, particularly region pediatric nurse practitioners and other providers who would be reporters. So that I would just ask if that can be corrected to PCP, that it should be, unless there's a particular legal reason for the word physician. You see it in several of the whereases, and it really jumped out at me.
Joe or Ben, can we make that change?
So I will note that I believe it's the 2 whereas clauses that reference physician are an exact replication of the city council ordinance. So Joe, I would leave it to you whether or not we could change that to primary care provider.
Sure. Just to jump in, I mean, I think that the whereas clauses use that term because that is the term in the particular ordinance that's being referenced there. So I don't know that it needs to be updated there, but I believe in the content of the regulation, Ben, if you can scroll down, that it does talk about
It absolutely does. I just wanted
providers, yeah.
Yeah, I just wanted to run through if it was not a big.
Yeah, I think that just gives you the context. It's not that, and to give you some additional context, there is actually a separate reporting regulation by the Board of Health as well that applies more broader under its disease control and prevention regulations. So I think we probably could update it if that's important to you, but it's actually, I think, just a reference to the ordinance as opposed to anything substantive, if that makes sense.
Understood.
Any other comments or questions from the board? And Ben, do we have any comments on this regulation from members of the public?
1 second, I will double check.
And while he's checking, I should ask Marla, based on Joe's information, do you feel like we should make that tweak, or what's your thought there?
If it's easy, yes. If it's going to hold this up and have to go through, formal legal, whatever it is, then no.
Joe, is it easy?
I don't know. I think we have to have a vote on it and then a vote to amend the agenda, possibly to vote on it, and then we'll repost the agenda with that added to it. Because of the agenda posting requirements, it gets a little complicated when we add things to the vote, but it's not too complicated. Put it that way. It's definitely doable.
It sounded too complicated. So
Okay.
let's let it go, is what I would say.
But I think the intent is important, that we remember as we're drafting things to be thinking about that. Thank you.
Absolutely.
I did receive 1 comment just now, I believe, that was referencing this regulation. It says, why hasn't a conditional assessment been issued by the city for housing over an X amount of age?
Conditional assessment. I'm not sure I understand that. did that come in by email or in the chat?
It's in the chat, and I can actually share, if nobody has objections, I can share the screen that has these questions on it, I believe. Maybe I can't. It says for lead painting is the follow-up. A
Yeah, I mean,
conditional
the lead-
assessment for lead painting has been issued by the city for housing over a certain age.
I mean, for rentals, that's the lead certification, although it's not based on the age of the house or apartment. It's for any rental unit. We don't have a requirement that people have their own homes tested for lead. Yeah, I mean, I think that the environmental aspect of this is really important to go through in terms of what more can be done.
And I just added the exact language to the chat in case I don't think it was viewable as I was trying before.
Okay. All right. Any further comments or questions from the board on this one? Okay. Is there a move to adopt this regulation?
So moved.
Is there a second?
Second.
All in favor?
Aye.
Aye.
Any opposed? Okay. Thank you. So we will then move to the rescission of the regulation regarding the sale of flavored tobacco. Unless I'm forgetting something, but I think that's next on our agenda.
That's correct. And I will share my screen here again. So I know you board members have had a chance to review this and it's very brief, but I will also share a quick history of this issue to inform you about why we're asking you to rescind this regulation. So in 2019, City Council enacted a bill that added to the Philadelphia Code, Chapter 9, Section 639, which was titled The Sale of Flavored Tobacco Products, and it restricted the sale of flavored cigars and flavored roll-your-own tobacco to licensed tobacco product distribution businesses. In response to this ordinance, the Cigar Association of America sued the city, claiming that it was preempted by state law from passing this ordinance and enforcing it. And that happened in June 18th, 2020. So shortly after the lawsuit was filed, the Board of Health approved the regulation that we're asking you to rescind, which was the regulation relating to the sale of flavored tobacco products. And this regulation essentially defined what flavored tobacco products were, so businesses would be able to easily, follow the ordinance. And it was a basically definition of a flavored tobacco product. After that happened, there was a preliminary injunction issued by the district court. So the case was in federal court, and the Cigar Association of America won an injunction against the city that prevented the city from enforcing the ordinance. And that injunction was recently upheld on November 24th, 2021 by the Third Circuit Appeals Court. As a result of the city losing that appeal, it's been determined that the city is, by the courts, that the city is in fact preempted under state law from enforcing the flavored tobacco ordinance. And as a condition of the settlement agreement that the law department has entered into with Cigar Association of America, one of the stipulations is that the Board of Health rescind any regulations that were passed pursuant to Philadelphia Code 9-639. So that settlement agreement is in place and is basically completed, except one of the steps is that the Board of Health rescind this regulation as the ordinance is no longer viable.
Great. Thank you. So I will say we're hoping this happens on the federal level since we are preempted here. Is there, well, firstly, are there any questions about this rescission?
Yeah. In leading to this, there were a lot of steps taken. And I understand what's being presented to us. Is there no other recourse? Can someone please let me know the steps that were taken? And it feels like a ceremonial vote since I'm hearing that there's a settlement and that the vote is finishing off the settlement that's been reached. So I'm disappointed and a bit frustrated. So can we hear about options and the steps that were taken prior to this coming to us?
Hi, so this is Joe Rosenberger Altman from the Law Department. And I unfortunately do not have a lot of information on the Law Department's decision to settle the case. I'm sure we can set up, oh, Dr. Bedigal, do you?
Yeah, I can probably answer that. So, I mean, we were sued. Essentially, we lost. We appealed, we lost. So we don't have another path forward, unfortunately, at this point with this. I mean, the industry made the case that this was preempted because it was primarily aimed at protecting kids. And the judge, although very sympathetic to our reasons for wanting this, agreed. And so that's kind of where we're at with this. It wasn't a settlement instead of a lawsuit. We just lost.
Can I ask a follow-up question? What happens if we vote against this or table it?
Yeah.
I don't know the answer to that, Joe.
So this is Joe. So I think if that happens, we could, if there's a desire to get I would ask you not to vote against it. If there's need for further briefing from the litigation team, I think we can hold that in executive session in a further Board of Health meeting. I will say that in the, that's what I'll say. And although I'm not privy to the specific details regarding the settlement, I will say that it is the city solicitor that determines legally how to pursue the city's legal interests best. So I don't, it is a unique situation that is different, for example, than in private practice, where the client entirely calls the legal strategy informed by a counselor. So it's just a very different posture than in outside of the city government.
Understood. Just last thing, I like to hear.
Absolutely.
Like to hear from colleagues on this, which is, I hear you. We're entrusted with the health, which sometimes entwines with the legal aspects, but remembering the steps that we went through, the idea of an executive session to understand more about this before flat out rescinding, I would just appeal to my colleagues. I feel very strongly about. That's it for me.
I agree with Marla. I think I'm very troubled by the fact that it seems like we are forced to vote in a particular direction, even if it goes against our conscience in terms of what the city should be doing. So, I mean, the city can agree that they're not going to do this, but having a mandate that members of the board have to vote in a particular way against what they previously voted on, taking into consideration the protection of the health of the city, I'm very uncomfortable with personally.
I totally agree. I agree.
Let's plan for an executive session. I don't want you all to leave this meeting tonight thinking that the law department didn't defend this law. They absolutely did. They did a tremendous amount of work to try to win this case. Many attorneys, many hours. So I just know that, but let's schedule an executive session.
But I think I'd also just want to understand what are the implications of this moving forward. So given this, having that conversation about what does this mean moving forward in regards to preemption, I think that's a conversation. Are there implications for how we should go about this in the future so that we're not in this predicament?
Mm-hmm. Okay, so we will schedule an executive session. I am writing things down. to go over
I
this
just want to
details.
chime in again for the same things that have already been said, but this is not an indictment of the law department. But again, for those of us that worked on this for so long and continue to ask for legal guidance, and knowing that the lobby groups are going to be very strong in their response, I think that's part of what you're hearing, is that we anticipated some of this and were given the idea that, you know, this was going to go through and be able to stick. So yes, we can go in executive session. Yes, we can talk about strategies, but it's just kind of frustrating. So
Yeah, and I hope this
Understood.
strategy, I would hope they come prepared to talk about what happens if we don't agree. This is gonna be hard to agree.
Yes.
Understood. Thank you all.
Great. Thank you. All right, next, an amendment concerning the effectiveness of the emergency regulation governing the control and prevention of COVID-19, mandating vaccines for individuals working and dining at indoor dining locations, as amended January 4th, 2022.
Hi, sorry. So I'm going to just walk through this a little, and hold on, this is the vaccination. Hold on one second, my apologies. So as this board is aware, you previously passed a mandate for individuals working and dining at indoor dining locations. Since that occurred, the case rates for COVID have gone significantly down. I can, I defer to Dr. Bettingall to speak regarding that, but I will speak briefly as to what this regulation does, which essentially recognizes that because 3 or more of certain metrics have been reached under Section A, that the indoor dining mandate is no longer in effect. And prior to this, the Department of Health has announced that they, as an enforcement matter, would no longer be enforcing the regulation because these metrics had been met. It further provides in Section B that if the commissioner determines that 3 or more of the metrics are applicable again, and that it is once again necessary to implement the indoor dining vaccine mandate, and so certifies that to the board and to the mayor, that it will go back into effect, and that would also be brought back to this board at a subsequent time. And it really depends on the level. So if Section B talks about an indoor dining mandate being effective with the option for testing in lieu of vaccination, at what the Department of Health is referring to as the caution response level, and that includes if certain metrics are met related to an average daily case count that is between 225 or more, but less than 500 cases a day. If hospitalizations are between 100 or more, but under 500 a day. If the current positivity rate for COVID-19 is under 15%, excuse me, I apologize, is 5% or over, but under 10%. And the average daily case count has not risen by more than 50%. And if 3 or more of those are applicable, then the mandate will be in effect, but with testing in lieu of being an option for businesses. And Section C talks about the indoor dining mandate being fully effective again without a testing in lieu of option. And that is if higher criteria are met. So if 2 or more of the following metrics, if the average daily case count in the prior 7 days is over 500, or excuse me, 500 or more, if hospitalizations are 500 or more, if the current positivity rate is 10% or higher, or if the average daily case count has risen by more than 50% in the prior 10 days. And then I'll turn it over to Dr. Bettingold to provide any further explanation as to the reasons for this and answer any technical questions.
So I'm happy to do that, but I wonder if there are any immediate questions before I talk about numbers and where we're at right now. So since the announcement last week, average case counts have continued to decline. And what we're doing is posting the current metrics once a week on the phila.gov/COVID website so that people can see where we're at for each of these metrics. So I think, let's see if this is true. I mean, it is true that it's posted. Let's see if I can pull it up for you. And can I share my screen?
Yes, 1 second.
Sorry, Ben. Okay. All right. Do you see my screen? I hope. I don't hear anything. Can you? I can't see.
Yes.
Yep.
Okay, great. So this is to get here. If you go to the home screen and you scroll down, you'll see this new widget here for the COVID response levels. You can click on learn more about Philadelphia's COVID response levels to get all of the details about what the metrics are. But at the top here will be the weekly update. So you can see that when we updated, it'll normally be Monday, but Monday was a holiday. So Tuesday, average new cases per day were at 102. Hospitalizations were at 222, the percent positivity at 2.3%. And of course, we hadn't seen a rise in cases at all. So we didn't have a 3% rise in the previous 10 days. And that metric of the rate of rise is really because that's been the earliest sign we've seen when there's been a new variant of concern hitting us hard. So in order to reach a point where we would roll back masks according to these metrics, we would need, I mean, I think hospitalizations will probably be the last one that we'll hit. So we would need to both drop our average cases per day under 100, and we're clearly almost there. And the percent positivity would have to go under 100%. And again, we're almost there. We already are not seeing a rise in cases. So, and this is designed so that it can spring back. You know, if we have a new variant, we already have this in place, so we don't have to pass new regulations. We can go back to masking or back to the vaccine requirement if we need to. Let's see if I can manage to unshare my screen. I think. Are you back to seeing each other?
Yes.
Okay. So, you know, and the idea of this, I talked about this initially when we passed this, was to have restrictions that are effective but are as least restrictive as necessary. So, you know, the vaccine mandate for indoor dining did a couple of things. It helped keep people who were not vaccinated out of a space where they would by necessity be unmasked. So we decreased transmission in those settings. And it caused a lot more people to get vaccinated. So particularly among the 5 to 11-year-olds who had the lowest vaccination rate, we saw a huge bump, about a 20% bump in a short time compared to the national average, which went up just a little bit. So, so I think it was effective, but you know, it's also pretty intrusive into businesses. And so as cases have dropped dramatically and hospitalizations are down dramatically, it seemed to make sense to go to something less restrictive. So I'll stop there, but I'm happy to answer any questions or just hear comments if you have them.
Cheryl, I'm curious how you came up with the specific numbers. I mean, what criteria did you use for that?
Yeah, so we tried to tie this to CDC metrics as much as we could. So the lines are, you know, they're approximate, adjusted for the Philadelphia population, but that line of 225 approximates the line between, I'm going to pull this up actually for you. Where are we?
Oh, sorry, Cheryl, I can share your screen.
You are. Sorry. I'm just trying to show it to you on the website because we put the information there just to have a little bit more transparency. Thank you, Ben. All right. So the average, the 225 per day is approximately the cutoff between the CDC's high and substantial levels of transmission. And the cutoff of 100 is approximately the line between substantial and moderate transmission in the CDC's rubric. And that's where they recommend masking in indoor public places in areas of substantial and high transmission. So that's where that metric came from. The hospitalization numbers really has to do with the load on the healthcare system. And, it's the hospitalization. So when we look at numbers for hospitals, as you know, we're looking at people both with who are in the hospital because of COVID and people who are there with COVID. And right now in Philadelphia, about 40% of people who are COVID positive in hospitals are there because of their COVID, and the other 60%, it's not helping, obviously, but it's not really the primary reason they're there. So this is in some ways aligned with historical, like where have we been for hospitalizations and other waves and what constitutes a load for our healthcare system. But this is a metric that I'm guessing in a few months we may need to change because as hospitalizations maybe get less linked to positivity, meaning like we may have more and more people in the hospital over time who are there, who are incidentally positive, but it's unrelated. Right now, 40% is still a fair, it's a reasonable metric for us that people are being hospitalized because of COVID, but that may not be as true going forward, depending on what happens with vaccination and with severity of COVID strains. And then the rise in cases, we did an analysis and we tried a bunch of different metrics for this of what do we see early on as Delta hit? What did we see early on as Omicron hit? And we tried different percent increases and we tried different, should we look at 7 days, 10 days, 14 days? And the 50% in 10 days seemed to correlate the best with being able to predict, a variant hitting hard before some of the other metrics went up. But it seemed to be the most reliable of the combinations that we tried. So I'm hoping that helps a little bit.
Mm-hmm. Yeah, thanks.
Sure. Other questions or comments?
Can you comment on where we are in terms of vaccination and boosters in the city as far as the data that we have?
Yeah, sure. So for adults with 1 dose, we're at 95%. Adults fully vaccinated, we are at, I'm going to pull this so I say the right number to you. It's over 81%.
Do we have number for?
81, sorry.
No, go ahead. I think you were about to say it.
81.1% of adults are fully vaccinated. For 12 and up, it's 90.8% with 1 dose and 75.1% fully vaccinated. And then for 5 to 11-year-olds, we're up to 53.6%. The national average is a little below 32%, so it's a very big difference. And then boosters, 31.8%.
And
yeah.
Are the disparities in the children the same as in adults, or do you see a different pattern?
So in terms of overall numbers, we've by a large number vaccinated more children of color than white children, but the percents are disparate. They've been improving over time. We had a lot of white kids early on, and then it's taken a little bit longer to reach some of the African American children and Hispanic children, but they're starting to catch up. So we still have a long way to go with 5 to 11-year-olds. But the overall rate for percents were at 22.8% for African Americans, 65.4% for Asians, 29.8% for Latinos, and 42% for whites. So definitely a lot more that we need to do there.
What's the evidence that the vaccine mandate is hurting restaurants?
So, I mean, I can tell you what the restaurants cite, which is that they're hearing from people who are choosing to go outside the city. The venues are losing customers to the suburbs. I'll say, people complain about a lot of things in the city of Philadelphia. So we try to be data-driven rather than complaint-driven. The factor to me that pushed to rolling this vaccine mandate back more than the complaints was that we did it because we had this huge surge hitting us, right? We could see Omicron coming, and then we could see the slope of that curve was just ugly, and we knew it was going to be bad. That's not true right now. So we have, we still have a little bit of disease in the city, but we just don't have that kind of prevalence at all. So it then becomes harder to make the case to do something that's intrusive for businesses.
But I mean, it's possible, as you noted, these mandates are a way to get more people vaccinated, and it's, yeah, we're doing good, and probably there may be pockets and areas where the vaccination and populations where the vaccination rates are lower. I'm sure, and those may cluster geographically and places where certain restaurants are located. So I don't know.
It's true.
It's a question for me. I mean, is it too soon?
Yeah, I will say that one of the things I had not anticipated that happened was all of the fast food restaurants decided to close to indoor dining. And so that did limit some of the impact that I think we otherwise might have had. Mm-hmm. Because if they don't have indoor dining, they didn't have to enforce the vaccine mandate. But yeah, we look at vaccine rates by census tract because the zip code data is too mixed. It's not granular enough. And so we've been focusing on the various census tracts. The other things that we're doing right now is we finally got our incentive program up and running. So we are promoting, it's $100 incentive for anybody who completes their primary vaccine series. For kids, they need parental consent for the incentive, although they don't need it for the vaccine. We're using the reminder function. So we have information in our system about who is due for that second dose, and so we can send reminders to those folks. Other questions or comments?
I have a question. So, and I think I've spoken about this before, going back to vaccination rates. I'm trying to think of when or if, I'm sure we all are, we get out of this cycle, right? Which is, okay, so we're here, and absolutely, I mean, as someone who deals with it at a college level, people need a break, and we're not, cases are way down, even though boosters are quoted at 30 whatever %. The fact is that so many people also had Omicron, which increasingly data suggests is as good as a booster. And, we have more data to look through, but for a certain amount of time. But having said that, if in a few months, say everything's lifted, knowing what you know about the rates of vaccination, boost, and whatever we've got, what are we doing such that we would have an idea that our hospitals wouldn't be nearly overwhelmed again? In other words, where are we? Such that, assuming that the vaccines are effective in some regard for the next variant and the next round, let's make that assumption, and there's another round of vaccine coming with seasonality in the fall, all things, the game, right? Would our system still be driven by those unable to or choosing not to be vaccinated? Are we far enough along in this, in Philadelphia, to make some declarations as we move the pieces here on this board?
Yeah, I mean, The fact that we're at over 81% of our adults
Which,
vaccinated,
congratulations, by the way. It's
it's
pretty-
all of but thank you. But yeah, so that plus, 95% with one dose, plus the prevalence of people who've been infected. I no longer really believe in herd immunity with this, but that's going to at least limit spread. And I frankly think that's a lot of what we're seeing right now. I mean, we did a lot of things. We've done a huge amount of work. Omicron hit very, very hard all over the country. And, I think a lot of people had it. So, what does that mean? It depends what future variants we see. And it depends how virulent they are and how the immunity transfers. There are lots of things we don't know. But it does feel like right now we are in pretty good shape. And the other thing is that I think it's important that we recognize when we are in pretty good shape and do let people kind of have a little bit of freedom then, because that gives us more credibility if later we have to do something else. And also, frankly, the importance of social connection and people having some normalcy in their lives in terms of the city's mental health is another piece of it. So,
Yeah. I'm sorry, just to finish up on that, I of course, I don't disagree. And I'd be surprised if anybody did. It's just that the question keeps me up at night, number 1 million, is, are the unvaccinated then just going to be our driver cyclically, and for how long? Because at the end, after all of these interventions and drivers built to have people be vaccinated, still in all, those people choosing not to, there are those still unable, but choosing not to, can form a wall driving us in a cyclic way continually. And so we don't have an answer here, but it's something that is definitely wholly frustrating, and I wish there were some way to get around it. Obviously, vaccination rates couldn't be on here, and there's some good reasons why. So, yeah.
I mean, I think the other, probably to me, the most important factor is international, is our ability to get vaccines to other countries.
Don't disagree. Yep.
Other comments or questions? And if not, Ben, can you tell us, are there comments? I know there were some that you sent earlier to the Board of Health. Are there other comments in the chat or what you've received that we should review?
Yes, I've started putting some that I've received by email in the chat, and I'm going to try again to share on my screen the questions that we've been getting in the chat function. I believe that's going to be the easiest way for the board members to review them. So I will share my screen.
So can people see the chat function? Because I'm not sure if you need to.
Yeah.
Okay. Is there anybody who can't see the chat function? Okay, great.
Okay, that's good. I will still try this, just
It's fine.
yeah, exactly. Unfortunately, it does not seem to be work.
Yeah, we can see it in the chat. We're just looking at section A right now, correct? We're not.
Can you see in the chat, you should be able to see comments from the public.
Yeah, we've seen the comments from the public.
Some of those are about schools and masking, but there's one about restaurants.
Yeah, we can see it.
Just for the record, there is also a lot of restaurants being opened. It's estimated to be about 20 or 15 to 20 new restaurants opening in the city. So the things is not that bleak that restaurants are in bad business. People will not open new restaurants if that's bad.
Okay, but we haven't discussed about the masks in schools yet, right? This is just this first part. Okay.
Yeah, sorry, I'm just making sure that all these comments are recorded. So if you can see them, that's great, but I'm just going to copy them all into the chat for the public as well.
I just want to ask whether this regulation or this change is in line with the Department of Health of Pennsylvania. As one of the questioner asking, are we going to be in line with the mandate coming from the Department of Health, the Pennsylvania Department of Health?
So the Pennsylvania Department of Health doesn't mandate vaccines in indoor dining places and doesn't mandate masking. We are stricter than them. We just can't be more relaxed. And I realized, Joe, that I think I jumped ahead and you probably had more to go through here before we went to public comments. Sorry about that.
I'm not sure that I did for the indoor dining mandate.
Okay.
Is there something specific that you're thinking?
No, just double checking. All right. Are there any of the public comments that you all, any other ones that you would like to discuss or engage? Is there a move to approve?
So moved.
Is there a second?
Second.
All in favor?
Aye.
Aye.
Any opposed? All right. Thank you. And finally, the third consolidated and restated supplemental emergency regulation governing the control and prevention of COVID-19, consolidated safety measures for full reopening and delegation of authority.
Hello again. I'm just going to walk through this fairly briefly. So this regulation does two things. One, it consolidates several previously adopted regulations and orders, regulations by the board, many of which adopted prior health commissioner and mayoral orders. And it also sets forth a circumstance for when certain masking requirements will be rolled back and make some clarifications to consolidated rules. It largely consolidates the second consolidated and restated regulation, the second consolidated and restated supplemental emergency regulation governing the control and prevention of COVID-19, and a 10th supplemental regulation that dealt with data reporting. So as you know, the board has been very active in passing several regulations and amendments as the ebbs and flow of the pandemic progressed. And this is just an attempt to put a number of them that make sense into one location related to what businesses need to do to remain open. I'm not going to go through the whereas clauses, which are basically a recitation of the ebbs and flows of the pandemic, as well as recent announcements by the health commissioner and the mayor related to the city's pandemic response levels that we discussed briefly in context of the indoor dining mandate. But I'm going to start just to go over some of these points. So if we go down to A, this just discusses that it is a consolidation, as we just discussed, of the second consolidated and restated safer at home restrictions and delegation of authority as that regulation has been amended, as well as the 10th supplemental emergency regulation governing the control and prevention of COVID-19, a second mandatory data reporting order. There's an attachment that really summarizes the rules, and I'll walk through that, as well as the differences from what is the actual consolidated rules. There's some minor clarification, and as I mentioned, some changes with respect to masking. B1 This is the more substantive change. Well, actually, let me go back up to B. I apologize. So there's some minor changes. There is also a rescission of the outdoor event mask mandate because the metrics to roll that back have already been reached. And then what this regulation indicates is that when the health commissioner determines that certain additional metrics have been met, similar to as we discussed in the indoor dining, when 3 or more of the following metrics have been met, the indoor mask mandate will roll back with certain exceptions for face coverings to continue to be required in indoor settings such as schools, healthcare institutions, and congregate settings. And the criteria that will trigger the health commissioner to so certify to the board and roll back those mandates is when the average daily case count of reported COVID-19 cases for the prior 7 days is under 100, hospitalizations related to COVID-19 cases are under 50, the positivity rate for COVID-19 tests is under 2%, and the average daily case count for reported COVID-19 cases has not risen by more than 50% within the prior 10 days. So when 3 or more of those metrics have been reached, the health commissioner can so certify to the board and the mayor. And those certain restrictions that we'll talk about momentarily more specifically will roll back. And again, those are generally the indoor masking mandates outside of those certain settings. Now, the section C talks about those regulations that continue to be applicable and are not affected by this third consolidated and restated emergency regulation. So separately, there's a communicable disease listing, reporting, quarantine, and isolation requirements. That's not affected by this. There's certain data reporting related regulations that are not affected by this, which is the 6th supplemental emergency regulation, which mandates certain data reporting, as well as certain data reporting related to the perinatal COVID-19 surveillance by the Division of Maternal Health, Maternal, Child, and Family Health. It also does not affect the long-term care facility related emergency regulation, the fines and penalties regulation, which increases the fines and penalties applicable to certain violations of board regulations related to COVID-19, and mayoral and health commissioner orders implementing regulations in between board meetings when necessary. It also doesn't impact the emergency regulations concerning vaccine mandates, specifically regarding the mandate for healthcare workers in higher education and healthcare settings, or with respect to indoor dining for workers and individuals. And we just discussed that regulation, which stands on its own. It's continuing the delegation of authority to the health commissioner, essentially to act as necessary in between board meetings to either impose additional regulations or roll back regulations previously promulgated by the board when it's appropriate to do so between board meetings, so long as the commissioner promptly brings it to the board for consideration at either the next scheduled meeting or at the next subsequent meeting if that's not reasonably practicable. And this just further discusses some examples of the types of orders that the health commissioner can implement. And these are all similar to the authority that's previously been delegated under prior regulations of the board. Similarly, there's a delegation of authority to the health commissioner to interpret and issue guidance concerning and relax the requirements and otherwise modify them. Paragraph E just discusses that in certain circumstances that authority may be delegated to other city departments that are better positioned. This has only occurred once that I can recall. I think it had to do with L&I and hours of operation for certain construction when there was construction related regulations that related to COVID-19. And it reiterates that the failure to comply is with this regulation or orders issued thereunder, or the outstanding regulations remain subject to the enhanced fines in the April 29, 2020 emergency regulation promulgated by this board. Okay, and so this will be effective when filed with the Department of Records, and it'll remain effective until suspended, superseded, or repealed. And now I'm going to go into the attachments, which is really the substance of the rules. And I'm just going to highlight here, unless there's questions or a desire for me to walk through the current rules, I'm just going to highlight where there's changes from what the board has previously adopted. So aside from just updating, oh, did someone have a question? I'm sorry. So aside from updating just terminology to be consistent with the current regulation, with respect to face coverings under section, let's go, section 1A 3C. Ben, are you able to? Yes, thank you. So there's a little bit of language just added to clarify that it's all schools and that schools refer to kindergarten through 12th grade. So it applies to all schools that are operating in the city. When we go down to D, right below that, right now the mask and mandate applies in any indoor setting, but then there's language that references that previous provision in the regulation where we discussed that this subsection 3D will not be applicable if the health commissioner has submitted a certification consistent with the regulation we just discussed, because certain criteria have been met, and if the health commissioner has not reimposed the requirements. The regulation also especially provides that the health commissioner can reimpose the requirement when she determines that it's appropriate. And then the rest is essentially just, the only other changes in this are adapting wording to be consistent with this, the terminology in this order. And then if we go down to, we're in D, there used to be a 3, excuse me, not a 3, I apologize. There used to be an E that provided that outdoor events with more than 1,000 or more attendees required masks unless the event was exclusively seated or certain other requirements are met. As we discussed earlier, that piece has already been rolled back. Other than that, the only other changes in this is some additional language clarifying that all businesses and organizations that are operating in the city must follow these safety rules as clarified by any guidance issued by the department. And additionally, under contract tracing, there's some additional detail provided that really was brought over from the 10th supplemental emergency regulation to be a little bit more specific about what requests the health commissioner may make. So requests for information concerning contract tracing can include name, date of birth, demographic information, contact information, including phone number, address, and email address, and such other information as specified in the request that the health commissioner has determined is necessary for the efficient case management or contract tracing purposes, taking into consideration the time sensitivity of such control activities. And then section 2 here is also added, again, just to be clear that information collected is confidential and is only to be used in furtherance of the department's obligations under the Disease Control and Prevention Act. And again, this is all language that was brought over from the 10th supplemental regulation. The last change is in D. So there is a change here regarding quarantine and specifically related to the prior regulation provided that quarantine was appropriate if an individual is fully vaccinated, which was defined as having received 1 dose in a 1-course series or 2 doses in a 2-course series. That has been updated to provide that if that a person must quarantine unless the person is up to date with their COVID vaccines, and it clarifies that for the purposes of these safety measures, up to date means that the vaccinated individual has received all doses of the COVID-19 vaccine for which they are eligible, as recommended by the FDA or WHO. And other than that, the changes are consistent with what we previously discussed. So just clarifying that all businesses and organizations must follow these rules and regulations, and changing some minor language to update and refer consistently to the terms used in this regulation.
Thank you, Joe. So, just making sure that everyone's clear that when we reach that all clear set of metrics where the indoor mask mandate doesn't apply, it still applies in some specialized settings. So it applies in healthcare institutions, congregate care facilities, and public transit, which is a federal mandate. And then it will apply still in K through 12 schools, early child care camps. What we talked about doing in the school settings is just revisiting in a couple of weeks. This is what's happening in other jurisdictions. New York State just announced the same thing. Revisit in a couple of weeks, we will have the benefit of seeing what's happening in other places that have rolled back mask mandates before we have to make a decision with schools. And we talked with the district about that, and they were comfortable. So we're communicating with our school partners on that. So any comments or questions?
I have some, but I've been doing a lot of that tonight, so I want to yield and see if others do before I ask. Anybody?
And I also just wanted to see if there were, oh, you're putting them in now, if there were comments coming from the public.
Yes, I'm receiving some more emails that I'm putting in the chat, and I'll also continue putting some from the questions section in the chat, but all the board members are able to see that. That's more for the public's consumption.
Okay, so in no special order, if we get to this place, first, well, let me ask this, which is there any utility, and I just thought of it, to have it be, instead of at least 3 of these 4, that it would be hospitalization, the hospitalization metric, and 2 of these 3?
So, I mean, the thinking in the 3 of the 4 to be able to reach all clear without the hospitalizations being all the way there is that that's going to be a lagging indicator. So, in both directions, right? We wanted the ability to not have to wait for hospitalizations if we see cases and positivity soaring. Wouldn't necessarily want to wait for hospitalizations to rise to do something stricter, even if we do it just short term until we know more.
I'm sorry. Okay, so opposite way. Stop right there. I was thinking,
you're thinking
in one direction.
Yeah, on the way down. It's complicated because people are doing this differently in different places. And some places are just using hospital admissions and not hospitalizations. And there are some reasons to do that. Hospitalization gives you a better sense of the load on the healthcare system. But one of the things about COVID hospitalizations is they go on for a long time. So people who are hospitalized may stay there for quite a while. So, if we did that, I mean, it's a little complicated to do something different on the way down than the way up, but it also means that we may just kind of be frozen in time a little bit when we don't necessarily.
I'm embarrassed that I didn't think about it in the different direction, so scrap that. I was only thinking of it on the way down. The other thing that shouldn't surprise anybody, and I throw it out there for our consideration, which is I believe that institutions of higher education, where admittingly there's a vaccine mandate, are in the same boat of themselves, many wanting to wait several weeks to see the impact of the city's lift, face coverings before making the changes. The burdens on those institutions include impact on accommodations in the classroom setting, both by faculty/teachers and students who declare an accommodation and want everyone around them masked, so that it becomes difficult. Great difficulty in contact tracing. Should we go in any direction, because what are now low risk contacts and we don't have to go after them in a classroom setting. We would have to now go after everybody, and that raises the specter of assigned seating or not. The ability to trust and understand the protection of a mask to the wearer, and whether or not there's one good modeling study one good study from Cornell, but there's not a lot out there that in that setting of a regular occupancy classroom college setting, with albeit greater than 95% vax rates because of the mandate, but just the same, everybody's in there. And then there have also, the national experience shows us that some of these students and staff live with elderly individuals or are themselves immunocompromised. All of that also puts a lag. I don't know if it's a benefit or not. Perhaps some other IHEs don't want that, and they want to be able to lift when you do. But I have to wonder why we wouldn't also do something that gives them a little wiggle room as the data comes in and they examine what their issues are.
I mean, so any institution, any business can be stricter than this. And one of the things that is enshrined in this regulation is the right to do that. That employers, businesses can say, institutions can say, you have to mask it, and that's fine.
I understand that. With all due respect,
Yeah.
Commissioner, it's going to give each one a different way to go at different times, and instead of moving together through this. So that's why I'm raising it. I don't see that anybody else has a concern about it. I know we have several institutions represented.
That's what I'm wondering. Are there other?
No. Then the last question I have on my list is for us to understand. So when we're at this point, which is very exciting, I don't mean to, I mean, it's right. This is an exciting time for a lot of reasons. What constitutes an ongoing public health emergency to be able to maintain vaccine mandates and other regulations when at the same time metrics allow us to lift the last area of face coverings?
It's a great question. I think there's still, for a lot of us, for all of us, a lot of unknowns in terms of future variants, beyond which we're not, I think there's a difference between lifting these restrictions, giving people a break, having a moment of, okay, let's have some normalcy in life, and declaring that we're done. And I personally am going to be really careful in my messaging. I'm hoping that next week we'll be announcing all clear. I want to be really careful in my messaging that doesn't mean the pandemic is over. It means we don't right now need restrictions, but that's government. That's not, what decisions do people make before they visit somebody who's elderly? What decisions do they make about where they go and exposures and things like that? Because if we look at what's happening worldwide, if we look at still deaths in this country, it's still horrific. But it is a question we will need to continue to grapple with. I mean, we can't forever call it an emergency. Other questions or comments? Can I ask folks to turn, or the board members rather, to turn to the chat and take a look at the public comments that have come in?
I'm sorry, Commissioner, maybe you could comment more on the timeline, since we have numerous comments coming in thematically about masking of K through 12. And you had mentioned the rationale to hold is not forever. Can you speak more to that?
Yeah, so the plan that we've come up with, which is similar, as I mentioned, to many other jurisdictions in the country, is basically we're going to wait a couple of weeks, and then we are going to reassess. We are going to talk with schools again at that time. If things continue to look good, if we're not seeing a rebound in places that have stopped masking, then we would go ahead and recommend that schools no longer require masking. And again, that will not mean that people don't have a choice, but we're just going to wait a couple more weeks so that we can see how this plays out. We're seeing, unmasking in many, many places in the country. So I think if we're going to see a rebound in cases because of that, we would be able to know that before we make a decision for Philly. So it's a short timeline.
Thank you.
And I will address, there's a question in the chat about whether the Archdiocese and private schools are obligated to follow the masking protocols of Philadelphia, and they are. The masking protocols apply to all schools in the city.
I'm still haunted by there is no way to add an extra 2 weeks or a set timeline for institutions of higher education to assess as well, but we are leaving them each to figure out what works for them because the issues are the same. That's why the things that I outlined.
Well, it's not that there's no way to do it. What do you folks think?
If I may, the issues are different even with the same institution because we have schools and colleges in different environments, clinical, non-clinical, classrooms, non-classrooms. So I think each university has to decide and customize it to the environment of that university. And I think we should wait 2 to 3 weeks, as the commissioner is saying, and decide based upon the statistics whether we change.
Just to be clear, that's not, so we were saying that the 2 weeks for schools, for 12 schools, early childcare and camps, but not necessarily for colleges and universities. And what Marla is suggesting is that we add colleges and universities to that 2 weeks. That would mean though that colleges and universities could not stop masking when we hit the all clear. So the question is,
for 2 weeks or whatever it's going to be. That's
right, yeah.
I'm leveling the playing field. There's not a question about it. Realizing that those legal issues, because this is creeping up faster, I think, than many people thought. And the legal issues, and I don't want to be self-serving here, but broadly speaking, are many. And I could be incorrect, but for those institutions, there's a lot of work that needs to be done. I know of the University of Berkeley in California, which also, universities tried to match what's going on in their city, but they hit bumps immediately. And there's all sorts of back and forth issues with accommodations, et cetera. So it's trying to even out the time for the institutions. And I don't hear my colleagues speaking out to this. So I stand back understanding that I'm a lone voice, and I respect that.
I do think it's important that colleges and universities can choose to do that. The question is just, would we mandate it?
I don't think you should mandate it.
So Marla, is the thinking mandating it because the implications of the school have the larger impact on the city?
It's multiple things. It also, with the word and the regulation, it buys time for families and others that will have different thoughts about it, understandably, to look at all of the impacting issues. On the other hand, if we don't, then it'll be whoever casts the first stone, and everyone will, pardon my expression, take a look at each other and see how it's going. Similar to what will happen in K through 12. Which is, which is K through 12, be looking to see, well, what is that experience? We've all been through a collective trauma together now for for just about 2 years. And the impact of that last lift will be very far reaching. But as I've said to you, there are accommodation issues, immunocompromised individuals who are going to get hit by this, make no mistake about what we're doing. And it's a minority compared to the vast majority of people, but just the same, we need to factor them in. And we don't have a lot of data of the classroom space, but Dr. Ismail, absolutely, I acknowledge that it may differ from college to college, space to space. So I don't want to be too self-serving on this one. Just make sure that we talked about it, because it's gonna be a hit to figure it out. But we'll find our way.
So I want to make sure you all have a chance to read the comments in the chat too. So we'll give another few minutes for that. Any comments that the board wants to discuss or engage with at this point? Is there a move to approve?
I move.
So moved.
Is there a second?
I'll second.
All in favor?
Aye.
Aye.
Any opposed? Thank you all very, very much once again for your time and your insights. We'll now adjourn. It is 8:01 p.m. And thank you all very much. Have a good night.
Cheryl,
Thank
can I
you.
just ask, we'll follow up about scheduling an executive session?
Yes, thank you.
Thanks.
Thank you.
Bye.
Take care.
Take care.